thanks to Dr. Namrata and Dr. Rajesh for inviting me. And I think my topic is slightly different from all the topic. I was not knowing this is a cornea and refractive surface. They told me that you can present cataract also. So this topic is slightly different. Anyway, we all know that cataract is most commonly performed surgery worldwide. And in the bag, IOL has been nowadays is synonymous with the cataract surgery. So if you are doing cataract surgery, we assume that you are putting the lens inside the bag. So in absence of adequate posterior capsular support, such as during complicated cataract surgery, it is often possible to place IOL in the ciliary sulcus and maintain excellent visual outcome. So a small complication, a small rent, we can place the lens inside the sulcus. Though it is not FDA approved, but it gives quite good results. Most of us have seen. The only catch point here is to put a 3-piece lens, not to put a single-piece lens in the sulcus. So compromised anterior and posterior capsular integrity can result from a variety of causes. We all know. I think I will skip the slides. This is important. The estimated 1 to 2% cataract surgeries in developed countries will have complication by vitreous loss. This again is a data. It's a generalized data. If you go in a teaching institute, it may be very high, while with the experienced surgeon, it comes to very low. So what are the options available to us? We have ACIOL, we have iris claw lens, and we have scleral fixation IOL. The outcome of all these three has been studied, and recent studies do not give any importance to one procedure. They say that all the procedures are good and they all gives a good results. As a cornea surgeon, we have seen a lot of explant of ACIOL. So for me, putting ACIOL is like a big no. I don't put ACIOL at all. Either I will go with SFIOL or I use a iris claw lens. Iris claw lens, again, I am not very much in iris claw lens. So this slide, like we have seen anterior surgeon and posterior segment surgeon both operate, and this is given both the results are almost equivalent. They do not have much advantage. So this is for anterior segment surgeon, they can do a good anterior vitrectomy. That is the catch. We have to do good anterior vitrectomy, and we should not leave any vitreous tag or vitreous wig in the anterior chamber. That causes the complication later on. So now I will be talking on suture fixation IOL. So we have a SFIOL, we have a scleral tacking, scleral fixation, or suture fixation. And both these techniques are quite old. It is not new. There are various modifications in all these techniques, and all the surgeons have done their own modifications. So if you see, the Sheriot and co-worker has started scleral fixation, interscleral fixation of IOL, while Malbran and colleagues had started a long time back in 1980, the suture fixation IOL in aphakic patients. These are the potential complications which we have with the scleral fixation IOL, that's lens dislocation, lens tilt, suprachoroidal hemorrhage, vitreous hemorrhage, retinal detachment, endophthalmitis, hypotony, ocular hypertension, cystoid macular edema. And this complication rate starts from 10% to 54%. So if your experienced surgeon does, it will come very low, while the beginners or while those who are learning stage, that it may go very high. Now, we can reduce this complication with the latest technique or with the modifications. So what are the advantage of suture fixation? Because I will be talking on suture fixation IOL. So the advantage is it looks very simple, and you can learn fast. It's relatively faster than doing the scleral tacking, pulling out the tricks. And you can fix many types of lens in this. So recent advance, we have a newer sutures that do prevents the subluxation of the IOLs later on. And we usually now either bury the sutures or cover the sutures with the scleral flap that prevents the chances of any complication like endophthalmitis and all. So these are the sutures. Initially, if you see, there was 10-0 monofilaments only, 10-0 prolines was available, and most of the surgery was done with that. And that in various studies is given that in 5 to 10 years, the sutures get degraded. So now we have 9-0 proline and Goretex sutures. I don't have experience with Goretex sutures, but 9-0 prolines are used. I will be showing some 4 or 5 videos. This is like a 4-point fixation we usually do in our center. So this is anterior dislocation of the IOL. Now, most of us refer this patient to posterior segment, but anterior segment surgeon can very well manage these cases because the lens is in anterior chamber, still not gone posteriorly. So the important thing is to always mark the site, and the measurement should be proper in this. And this is the important technique, the real load technique. That is important thing to learn. Once you learn this technique and you are good with this, you can do any sort of variation in suture fixation IOL. So if you have a single sutures, you can bring it out and tie both the side. If you have two sutures, straight suture, you can just bring the suture directly and directly tie in the two sides. So I have a single suture, so I am tying it. These are the plate haptic lenses. Many companies are having. This is from Apasami. You have lenses from Zeiss, and the lot of other companies are also having, which has eyelets. So you can just insert the sutures from the eyelet and tie it. So here the important point is you put multiple throw. It is not tensor monofilament, so it will not remain, get loose enough. So you have to put multiple throw. I used to do at least 8 to 10 throws in this. And then the other thing is that you should bury the suture inside, because the exposed sutures get degraded faster. So when the suture is inside, it will not cause any irritation and it will not get degraded. So this is, the burying is very important. At the end of surgery, you see the well-centered lens. This washing the anterior chamber. And in this, all anterior segment surgeons should understand, we should not use viscoelastic, too much of methyl cellulose. If you have other high density viscoelastic, that is preferable to the methyl cellulose. So this is another case. Here, surgeon was not prepared and he has not planned for anything. And because it's a subluxation, very hard cataract. So the lens has tilted and now the lens is floating in anterior chamber. So there's no point manipulating more. Just what I did was I just removed the lens out, doing a large section because it's a very large nucleus. Now the option was only one foldable lens, that is Ultima lens. We were not having 3-piece lens at that time. So how to fix that lens, I was just wondering. Then just this vitrectomy, as I told you, vitrectomy is very important. We can check with the stack with. So this is the lens. So I just pull the lens, whether it will remain stable or it will get tilted. And I thought like, okay, it will remain stable in the chamber. So I passed the sutures from the substance of haptic from both the side. We have to be very careful. Both the sutures should not get entangled. Sometimes the lens roll up and it will cause problem. It cause tilting. So you have to be very careful with the sutures. The suture should be in proper orientation, and both the sutures should be in a the direction of the suture should be proper. This is again important. You have to hold the needle properly because this is very sharp needle, so it can catch any tissue. So once you have extruded from both the sides, you can just put the lens inside in correct orientation. The orientation has to be proper, otherwise lens will roll up. And suture should not be very tight. If you put a very tight suture, it will cause again problem. And suture should not be tight in one side. You have to titrate. So tie one side and then other side, and then you pull the last. And because this suture cannot be buried, so you can make a flap and put the suture behind the flap. And don't cut the suture very small. You have to cut the suture slightly bigger so that it will remain flat. If a smaller sutures can protrude out from the sclera, and later on it can cause problem. So sutures size should be slightly bigger so that it will remain flat inside. This is the end, and the lens is very well centered. Now people are using this Goretex sutures instead of like 10-0 or 9-0 Prolene sutures. So this, they say that this is non-absorbable suture, so it will remain for lifelong. Now some other, uh, if you have a partial support, partially the capsule is lost and partial support is still there, we can use the same technique. We can tie from the one side and make the lens stable. So once I am using iris hook, I can see there is almost 180-degree anterior capsule support is there. This is sensor lens, three-piece sensor lens. It remains very much stable in the anterior, in the sulcus. And this is, I'm just tying. I have made some serration. I've made some so that this not do not slip. Once I tie it here, I am very much comfortable. The lens will not go anywhere. Inferiorly, it is also only supported by the capsule, and superiorly, it can be supported. It is supported by the suture. So we should not put a single piece lens in the sulcus, because it never remains stable. All the UGS syndrome, glaucoma, and everything occurs with that, and it can cause like sunset and sunrise signs, which we have seen. So now this lens dip down, and almost 180-degree dialysis is there. So this lens we have to, if it is less than 1/4, we can put three-piece lens very comfortably, but it is a bit larger. And if you put the haptic comes in that area, you can again go. So it's better to suture it. Now that was superior suture, that was more easy. It is inferior. Again, the technique has to be same. The lens should be implanted in the sulcus first, and then I'm just tying it. The manipulation is done in the sulcus. And then the haptic is tucked in behind the iris, both the haptic. Now you can tie the suture. Again, it should not be too much tight. If it is too much tight, it will cause again tilting of the lens. So it should be optimally tight, and this has to be titrated. Now this lens will not go anywhere. So now some other, like what I have done is, after seeing this 4-point fixation, you can fix it there. Now the lens is very well stable in the sulcus. So why to fix it? Just put a suture sling behind and put the lens over that. This is one case. You can see the suture behind. This was not proper. It has come in the center. Ideally, it should be here, and center should be clear. So this is one of the oldest video. We can make a sling of 2 loops, that is 4 millimeter away. These markings are very important. It should be some 2 to 2.5 millimeter from the limbus, and the gap between the two sutures should be 4 millimeter. Because most of these lenses are 6 millimeter, so it will remain over that. And just past the suture. This is a railroad technique, which this has to be learned if you want to do a suture fixation SFL. This has to be learned. And if you are good with this, you can do all type of suture fixation. You can easily bury these knots so that it will not cause irritation. Vitrectomy should be thorough and proper. This vitreous was holding this iris in superior area. Now, if after vitrectomy, the iris will become slightly much better. And this lens has to be placed in the sulcus first, and then it has to. Now it is very much stable. Just doing a PI. The important thing, we need not to do all this. It was the first case, so I've done a conjunctival resection. You can directly go without doing a conjunctival resection after marking. And the other thing is that we can use 3-piece lens instead of single-piece lens. And this idea came, you can see the lenses are very much stable. These are all complicated cases. And the suture is holding the lens in the place. And this video, you can see the lens, even without support, is stable in the anterior chamber. I will just run once more. There's no PC support, but lens is very much stable in the center. That means in due course of the time, this 3-piece lens, the heptic get fibrous in the sulcus. That's why this lens is stable. Thank you.